Hello, my name is Richard Urman. I'm an anesthesiologist at Brigham and Women's Hospital, and the title of my presentation is Non-Operating Room Anesthesia Challenges in Adult Patients. In this presentation, we will discuss preoperative and patient triage challenges, patient outcomes, including closed claims data, quality, safety, and management challenges, and future directions. Listed on my disclosures, I also want to acknowledge Dr. Karen Domino for providing ASA closed claims data for this presentation, as well as funding from APSF to improve NORA safety. We published this paper a few years ago using NACOR, National Anesthesia Clinical Outcomes Registry, to specifically look at trends in non-operating room anesthesia over a 5-year period from 2010 to 2014. And as you can see in these graphs, the number of NORA cases has continued to grow as a percentage of all anesthesia cases. Age of patients continues to increase, in many cases more so than OR cases. Patients who are ASA 3 to 5, the percentage of those patients as a percentage of all cases continues to increase as well. And these are NORA cases are in red. This is another slide from this paper highlighting top 5 non-operating room procedures. And no surprise that they're mostly GI-related cases, colonoscopy, upper endoscopy, ERCPs, as well as ECT and elective cardioversion cases that comprise a significant chunk of all NORA cases. NORA, as you know, and that certainly has been happening over the last few years, is what we're seeing is a significant medical and surgical overlap in terms of case complexity in all subspecialties within NORA. From vascular procedures to ablation to certain cardiac procedures and so on. Briefly, we'll discuss patient selection and evaluation. Some of the common obstacles to pre-procedure evaluation of non-OR cases, that is endoscopy, radiology, cardiology, pulmonology, radiation oncology, and so on, is the sheer volume of these cases. And the question always becomes, if you do have a preoperative clinic, can that clinic and the resources that you have accommodate all of these non-OR patients in addition to a large OR volume? And ultimately, who pays for these services? Care coordination is really important, but oftentimes, as you know, these are direct access patients that you really only approach them on the day of the procedure. It's certainly important to be efficient, but we also have to be safe. And oftentimes, what we see is a lack of formal triage processes, both in and outpatients in NORA settings. In terms of triage protocols, there's clearly a lot of variability across different institutions. Education of non-anesthesia providers about patient selection and optimization, alignment of incentives. We do know that nationally about 60 to 70% of procedures are booked less than 48 hours of the day of the procedure. It's important, if you cannot do a full evaluation of these patients, at least get some information from them through patient questionnaires, and have a system in place to do so. But oftentimes these patients will be evaluated for the first time on the day of the procedure. So these are some of the challenges that a lot of institutions are facing. This is just an example, sort of a sample matrix for patient triage. If you have different facilities, say an inpatient versus a hospital-based facility versus an outpatient facility, and really the decision tree would be, does this patient need a preoperative clinic evaluation, or can they be seen on the day of the procedure? Obviously depends on their medical condition. Where's the best place to do this procedure, in the freestanding facility versus a hospital-based facility? And do you need an anesthesia consultation? This is just one example, and institutions have developed their own triage criteria for something like this. The key here is to have one in place. This is an interesting paper that was published by gastroenterologists. And really, the goal was to develop and validate a clinical prediction score in patients undergoing upper or lower endoscopy to essentially, it's a risk stratification score to predict who would do well and will tolerate sedation with fewer complications. For example, ability to complete the procedure just under, for example, midazolam and fentanyl sedation. And they developed this protocol looking at specific patient characteristics. As you can see, younger patients received a higher number of scores, and the same for colonoscopy, taking into consideration things like BMI, benzodiazepine use, opioid use, and certain psychiatric conditions. And this calculator is available online, as you can see in the right upper corner, where you put in all that data, whether you're having an EGD or a colonoscopy. And you can see I did this for a patient who is in that age range, who has some abdominal pain as the indication for the upper endoscopy, for example, a male, and who's an opioid user. And you come up with a score you see on the bottom where the red arrow is of 10. And that puts patient in a risk category 3, defined as a 20% risk of a difficult sedation or high sedation requirement. Again, there's a need to further validate and develop risk calculators such as this. A little bit about patient outcomes in NORA settings, what we know, and what are some opportunities for future research. So this is an interesting systematic review meta-analysis, basically looking at patients who presented with an acute ischemic stroke. And the question was what they call conscious sedation, non-anesthesia directed sedation versus general anesthesia, presence of an anesthesia provider. What is the impact of at least anesthesia care on the patient? So they identified 9 studies, some with general anesthesia, some with non-anesthesia directed sedation. And what they found, interestingly, there were higher odds with general anesthesia of death, respiratory complications, lower odds of good functional outcome and successful angiographic outcome. There was no difference in procedure time. And the authors suggested, based on the studies that they were able to identify, they actually may be worse outcomes with GA versus sedation. And there are lots of papers out there looking at this very question. Obviously, there are significant study limitations, mostly selection bias. This is a retrospective study, which patients were slated to receive anesthesia care and which were not. Sometimes had to do with the severity of a stroke or other comorbidities, for example. And oftentimes we don't see long-term neurological outcomes, which would be interesting to look at, whether anesthesia type actually impacted those outcomes. We do realize that an RCT may not be possible in these types of cases. So this is the data that we have. This is another one, EP lab. And what they found is that anesthesia involvement, when patients received a GA, for example, for AF ablation, there were fewer overall complications. And then they did a follow-up, a 17-month follow-up, and 88% of patients who received general anesthesia were free of arrhythmias versus 69% who received sedation. Also, patient immobility with general anesthesia, improved accuracy of mapping and catheter stability. Fluoroscopy time, for example, procedure times were actually shorter in the GA group. Obviously it's, less radiation exposure and, more efficiency. And you also recognize that we have an anesthesia provider in the room, that's an extra set of hands to help if there are any complications, things like that. The other thing to emphasize, again, looking at EP lab, patient satisfaction is important, right? It's important to us as anesthesia providers. It's important to the hospital. And what the authors found is that patients prefer GA in many cases. They ranked 67% of GA patients rated their experience as excellent versus 52% overall. And they prefer GA if they had to have another procedure, for example. And so this is an important point. There are lots of papers on endoscopy, colonoscopy in this case. This was published in JAMA Internal Medicine, looking at complications following colonoscopy with anesthesia assistance. This is very interesting. They used the administrative database. 21% of patients received anesthesia services. And they looked at complications, right? They looked at aspiration risks, perforation, and splenic injury. And interestingly, they found that anesthesia services for colonoscopy were associated with a higher frequency of complications. And they posited that this may reflect the impairment of normal patient responses with deep sedation. There are significant limitations of this particular study. Obviously, it's a non-randomized observational study, obviously retrospective data. It's not adjusted for differences in case mix, choice bias of sedation versus anesthesia by provider, and of course, not all patient comorbidities were accounted for. Finally, this paper, again, in the gastroenterology literature, compared propofol sedation and colonoscopy, and really looked at, an ability to complete the examination, right? So it was actually what their conclusion was, ability to complete examination, colonoscopy, polyp detection, in terminal ileum intubation. So being able to essentially complete the procedure was dose dependent, looking at propofol. And they basically found that propofol-mediated sedation compared to midas-fentanyl combination, for example, was associated with better examination performance and improved outcomes. Again, lots of papers like this. What we just have to, going forward, understand the limitations of some of these studies, in terms of power, in terms of underreporting of complications. What drugs were actually given and how much certainly matters, use of supplemental oxygen, and so on. A little bit on closed claims data related to NORA. A lot of the data comes from ASA Closed Claims Project. Again, data was provided by Dr. Karen Domino with permission, and some of the CRICO data, some of the work that I have done myself. So this paper we published using CRICO data, which is our malpractice insurance company, looking at claims against anesthesia providers in the GI suite. So it's fairly recent data, right? And the patterns that we see is a lot of it has to do with airway, right? You see the pattern of airway issues resulting in hypoxia, bradycardia, hypertension, cardiac arrest. But also what I wanted to highlight in this particular study is the role of comorbidities. So a lot of these patients that suffered significant injury or death were sick. A lot of them had CHF, lung disease, significant obesity, diabetes, and so on. That's a recurrent issue in a lot of these cases. These are ASA closed claims data. So we published this paper in 2017 looking at claims that events that occurred up to 2012, the occurrence of alleged injury. And what you can see, so the blue is NORA cases, OR is orange, and little star means it was statistically significant. So you can see that there were fewer cases in NORA that resulted in temporary or non-disabling injury. Permanent disabling injury, about the same. Death, NORA claims resulted in death more frequently, and that was statistically significant. So a very interesting finding. Again, looking at overall, so we use NACOR as a sort of to look at all cases. That's an Anesthesia Quality Institute's database that contains about 25% of all cases nationally reported. So we used it as a sort of a denominator. So NORA comprised at that time about 20% of all cases reported in NACOR, and 81% were OR-based cases, right? But if you look at malpractice claims, there were actually fewer NORA cases represented compared to all malpractice claims. So that's interesting. However, if you're looking at ways to improve care, right, and to really understand what were the triggers, what were the contributing factors to significant injury in patients. In NORA, you have to, one thing is to look at individual types of procedures. So this is just GI procedures. And you can see that a significant chunk of closed claims procedures were related to ERCPs, 15% of all NORA cases, even though ERCP is only 4% of all NORA cases nationally. And what we highlighted here in red, again, is interesting that in closed claims cases, and I already mentioned this, patients tend to be sicker, right? So only 29% were healthier patients. A lot of the emergencies resulted in claims in a NORA setting, 20%. And MAC was the choice of anesthetic in 88% of all closed claims in NORA, even though MAC is only about 49% of all cases nationally reported to NACOR. So an interesting finding. And again, just to drill in, just to look at this in more detail, again, orange is OR cases, NORA is NORA cases. These are all closed claims, right? So MAC was cases that had MAC and resulted in injury were overrepresented in NORA cases, right? Significantly higher MAC cases, respiratory events as well. NORA claims had a much higher rate of respiratory events. No surprise, right? And then a lot of them were actually preventable by better monitoring. Again, more so than claims seen in the OR cases. Substandard care, again, that's based on reviewer comments that review for closed claims. NORA, again, significantly higher incidence of substandard care in NORA locations. Payments were about the same, not statistically significant, but just as high, if not higher, in the NORA setting. Common damaging events, inadequate oxygenation, ventilation, about 32% of all NORA claims. Aspiration of gastric contents, difficult intubation, esophageal intubation. Again, these are all airway-related complications. Cardiac events, sometimes cardiac events were a result of inadequate oxygenation, ventilation, or aspiration, for example, and, oxygen deprivation. And 5% were allergic drug reactions, things like that. So lessons learned. Again, these are unpublished data for now, but issues had to do with anesthesia machine, cart, equipment being available. Ultimately, comes down to having the same standard of care in these NORA locations. One of the things that was clear from reviewing some of these records is consider endotracheal tube in the prone position. Mostly in ERCPs, for example, that some are not done with endotracheal intubation, is in patients with significant comorbidities and risk factors such as obesity, OSA, anticipated difficult airway, patients who have chronic pain, opioid dependent, substance use disorder, and procedures that are expected to be long procedures. And ultimately being prepared for emergencies, having all your equipment in place, the other factors that were identified as patterns. Just a little bit of NORA economics. This could be a whole other presentation, but really trying to link that to patient safety and quality and looking into the future, right? So healthcare is changing. Anesthesia specialty is being affected. Certainly NORA is being affected in the same way in terms of value-based, emphasis on value-based care and all the metrics that have come out with an emphasis on quality, a shift from volume to value, and of course value-based reimbursement models, bundle payments, and things like that. And it's important certainly for anesthesia providers to be part of these conversations on a hospital level and national level. The increasing importance of patient-centered outcomes and patient experience, as I mentioned to you, sometimes you, as part of the study, you ask patients, how was your experience with anesthesia, right? Emphasis on disease prevention, system-wide care coordination, all of these things are impacting anesthesiology and certainly NORA practices as well, increasing importance of IT systems, right, for scheduling, data sharing, preoperative evaluations, and data gathering and things like that. So the question is, looking at NORA, how can anesthesia practitioners work with non-anesthesia colleagues to add value, right? Given what I just mentioned, certainly thinking about hospital levels. So this paper is currently in print. We came up with, you're familiar with the value equation that you see on the bottom there, right? But we came up with a more a framework that's specific to non-OR cases. And what does NORA value look like, right? So you have your standard outcomes, clinical outcomes, quality metrics, patient-reported outcomes, as I mentioned, efficiency, operational outcomes, very important, and the resources that are needed to achieve all of this, right? Direct costs, indirect, and capital costs. But we also added enabling principles that I already alluded to, right? Culture of patient and provider safety, appropriate patient selection, perioperative risk optimization, and efficient deployment of personnel, space, and resources. So all of these are important factors to really inform the NORA value equation, if you will. And, anesthesia providers obviously have been working with their non-anesthesia colleagues, administrators, helping with pre-procedure and risk assessment, our ability to deal with unexpected events. If you think about what value we deliver in this setting, right? Improve efficiency, patient satisfaction, improve lesion detection and colonoscopy completion rates, as I showed you some of these papers, better quality. Perhaps some of it will be at the expense of slightly higher cost of anesthesia presence, and how do we work together to make sure that, we maintain the services that we expected to provide. The other thing that obviously is directly related to quality of care, things that impact patient flow, efficiency, anesthesia staffing, is creating NORA scheduling rules, right? And that is, things like booking rules, release time rules, bumping rules, add-on rules, right? The lots of emergent, urgent cases that come along. How do we manage them efficiently so that we use the limited resources that we have in these settings most efficiently, right? Overlapping case rules, realistic scheduling, and of course, completing pre-procedure H&P, right? All of these things will help with efficiency and quality of care that we provide to these patients. And just as importantly, moving from siloed institutional budgets more to strategic partnerships. And I preface my discussion by saying, this is a partnership, right, between anesthesia providers, non-anesthesia providers, hospital administrators. And as we try to, achieve the same goal, right, of improving healthcare value that we deliver, improving outcomes, going back to the equation that I showed you, and at the same time being mindful of costs associated with that. How can we work together? And that has to do with, looking at patient outcomes and efficiency metrics and things like that. So very briefly, in the remaining time, I just want to talk a little bit about ongoing research that I'm involved in and a few other people. So this study was recently funded by APSF, and it is really all about improving safety in non-OR locations. And the title of the study is Development and Testing of a Trigger Tool, and I'll explain it to you in a second, to identify cases at risk of adverse events in non-operating room anesthesia. And some of you may be familiar with trigger tools. There's lots of literature on it, not so much in the anesthesia setting, but they're really important, relatively new developments in detecting adverse events, AEs, right? The trigger tool methodology essentially uses surveillance algorithms to identify patients at risk for an adverse event. So you can essentially identify potential AEs prospectively, so you can do something about this, right? A lot of it has been done on the outpatient setting, for example, certain lab values that come back abnormal, and that could be an indicator of something else going on with the patient, and how can you intervene early to prevent harm, for example. So we tried to introduce the same methodology into sort of the anesthesia practice. So the presence of risk factors identified via a pre-procedure checklist, for example, could trigger a change in location, anesthetic plan, or additional staffing, equipment, support to reduce potential patient harm that's more specific to anesthesia practices. And the goal really of this study is to try to adapt this trigger tool technology idea to the NORA context. And really, as there's such a need for prospective action to prevent patient harm, right? And at the end of the day, we want to create a tool that anesthesia providers and non-anesthesia providers can use to identify cases that potentially could result in a complication, and what can we do prospectively to prevent those from occurring. So we have identified at least a framework. This is an ongoing study with potential triggers, and no surprise, right? So, patient factors, advanced age, comorbidity. Certainly, I showed you this SCOPE algorithm that was designed by gastroenterologists, intended to predict something similar to that, right? Based on specific patient demographic characteristics. Anesthetic planning, right? If the patient doesn't have a preoperative evaluation or preparation, should we pay more attention to this? Procedure type and complexity, right? As well as procedure site. Is it an office-based setting, a surgery center, a hospital-based setting, for example? Anesthetic factors, right? Deep sedation, availability of equipment, supplies, personnel, things like that you can identify prospectively. And timing of the procedure, right? I mean, most of the elective cases get done during the day. Some get done later in the day. And it is an important factor. We identified that in some of the closed claims cases, for example, as an issue. So the plan really is to use data from the ASA Closed Claims Project, and I showed you some of the data that we've been reviewing, and compare this to sort of national databases, NACOR, for example, and do a systematic literature search. And then we, in the process of setting up a modified Delphi technique with an expert panel of anesthesiologists, CRNAs, NORA, nurses, and proceduralists, and really kind of try to understand which triggers should be incorporated into this. And we're being informed by closed claims data as well as other published data that's out there, right? And then ultimately, modify the trigger tool and come up with a semi-final product, and then prospectively test the sensitivity and specificity of NORA, a trigger tool to identify cases at risk for NORA. So using some sort of low fidelity simulation, case-based simulation. So this is an ongoing project supported by APSF, so more to come on this. So in conclusion, obviously there are a lot of challenges ahead. And some of the challenges that we identified is, of course, patient selection, optimization of patient comorbidities, and really working with our non-anesthesia colleagues to improve patient safety and systematically designing pathways such as trigger tools and triage protocols to really try to improve safety and identify problems early on before they occur. So two things I wanted to highlight. One is a second edition of non-NORA anesthesia book that we published. Some of the things that I discussed are in this textbook. We certainly talk a lot about quality, safety, efficiency, and patient outcomes. And the other is very exciting. There's an APSF Stolting Conference. It's an annual event. And this year, the topic is non-OR anesthesia. And we're looking at all non-OR settings, hospital-based as well as freestanding facilities such as office-based settings. And it's a 2-day conference in Nashville right after Labor Day. And if you're interested, you can go to the website and check it out. It will be both in person and virtual. If you have any questions, here's my email. Thank you very much.